Hello and welcome to New Paradigms for Treatment and Management of Retinal Vein Occlusion, a virtual live webinar. I'm Arshad Kanani with CRI Associates and University of Nevada, Reno School of Medicine in Reno, Nevada. And it's my pleasure to have my co-chair for this program, Dr. Caroline Baumal, who's Associate Professor of Ophthalmology at Tufts University School of Medicine in Boston. Welcome, Caroline.
Hello, good morning, Arshad.
This event is supported by an independent educational grant from Regeneron Pharmaceuticals. Next slide, please. These are the accreditation statements. I'm not going to read. This is a CME event, and you will get 1.5 hours of credit. Please follow the instructions sent to you to claim your credit after attending this activity. The evaluation instructions will be sent in a separate email within 2 hours after the completion of the webinar. Please complete your evaluations in 14 days after attending this activity, and certificates will be emailed to you immediately after completing the evaluation. Here are the learning objectives of today's talk. We'll analyze the pathophysiology and diagnosis of retinal vein occlusion with special emphasis on integrating novel OCT algorithms into clinical practice. That talk will be given by Dr. Baumal, followed by my talk, where we talk about individualizing therapy for anti-VEGF inhibitors, as well as intravitreal dexamethasone for optimal patient outcomes in patients with retinal vein occlusion. We'll also outline upcoming clinical trials of novel therapies for retinal vein occlusion. So without further delay, it is my pleasure and honor to have my good friend, Dr. Caroline Baumal, to give her talk on retinal vein occlusion, pathophysiology, diagnosis, and imaging. Go ahead, Caroline.
Thank you for having me here. It's really a pleasure, and it's always nice to see my good friend Arshad. Although we can't be in person, this is, I'll take this. So I'm going to be talking about retinal vein occlusion. We can see this picture here. Obviously, something's wrong. We have retinal hemorrhages and cotton wool spots. These are my disclosures. I'm a consultant for Genentech, Novartis, Zeiss, Aura, and EyePoint. So before we talk about retinal vein occlusion, let's start with the pre-test clinical vignettes. Optical coherence tomography, also known as OCT. Which of the following is true? OCT uses sound waves to produce retinal images. B, OCT gives an optical biopsy of the eye. C, OCT requires intravenous injection of dye. Or D, OCT has not been used in phase 3 pivotal trials. I'll give you about 30 seconds, make your best choice, and we'll discuss the results at the end of my section. That seems about 30 seconds. On to the next question. Here's pretest question number 2. Which of the following is true about retinal vein occlusions? A, it is most common in young individuals between 20 to 40. B, it is a rare cause of retinal hemorrhages. C, it is the second most common retinal vascular disorder in the elderly. Or D, it requires fluorescein angiography for diagnosis. Just a few more seconds to make your best guess. Perfect. So before I start my section, I always like to start with my summary or my key points. These are the following. Retinal vein occlusion, also known as RVO, is a common retinovascular disease. It's also called central retinal vein occlusion, CRVO, or branch retinal vein occlusion, BRVO. What does retinal vein occlusion cause? Well, it can cause macular edema and or ischemia that can compromise central vision. It can also produce retinal neovascularization that can lead to vitreous hemorrhage, tractional retinal detachment, and vision loss. It can also produce iris neovascularization, leading to neovascular glaucoma. A few other key points. Fluorescein angiography is traditionally used to evaluate retinal vascular circulation in RVO. OCT is used to follow the treatment response of macular edema. And OCT angiography is a novel, non-invasive technique to image retinal vascular flow, which can assist in diagnosis and treatment of RVO. So I like to start off with a case. This is a patient who's had poor vision for 3 months, vision measured 20/100. And we can see in the color fundus photograph on the left that there's some hemorrhages in the supratemporal retina. There's also some irregular vessels just superior to the optic nerve, 2 big clumps of vessels. And if you look supratemporally, there's some sheathing along the retinal vein, there's some cotton wool spots, and in the macula, there's some hemorrhages with some exudate. This is consistent with a supratemporal retinal vein occlusion. And it's interesting, this patient waited 3 months due to the COVID pandemic. So they were delayed in presenting to come see me. If we look on the upper right-hand side of the slide, you'll see this is an en face OCT, which shows all of these cysts within the retina. And in the bottom right of the slide, we see an OCT B scan showing these elongated retinal cysts. This is all consistent with a supratemporal branch retinal vein occlusion and macular edema. Here's the OCT-A of this picture, the OCT angiogram, and this is after 1 anti-VEGF treatment. Arshad will tell us a little more about that after. We can see here, this is another way of looking at the retina. On the top row of images, these are OCT-A images, which is a non-invasive way to look at retinal-vascular and choroidal vascular circulation, and the arrow points to areas of non-perfusion. The middle row of pictures is called en face OCT, and we can see that there's a lot of cysts, most prominently in the deep retina, and the bottom image is the typical structural OCT that we're used to seeing. So that was after 1 anti-VEGF. Patient does not look a lot better. But after 6 anti-VEGF injections, now the patient's vision has improved. We can look at the color fundus photo. Most of that hemorrhage is gone. The exudate is gone around the fovea, but there's some RPE changes. We look at the structural OCT on the bottom of the slide. We can see the foveal depression has returned and the cysts are gone. And if we look at the upper right, we can see the details on the OCTA more clearly. So that's illustrating a typical sort of patient with a branch retinal vein occlusion that we see in the office who had a good response to treatment. And retinal vein occlusion is the second most common retinovascular disease behind diabetic retinopathy. Typically, patients present with one eye affected, although 10% of the time it can be bilateral. And for this reason, it's really important to identify and treat risk factors because it can save the sight in the eye with the vein occlusion, and it can also help to prevent it from happening in the other eye. There's a classification system for retinal vein occlusion. In the middle, it's all precipitated by thrombus formation, okay? And this can lead to either occlusion of the central retinal vein down to the left of the slide, or occlusion of a branch retinal vein as seen on the right-hand side of the slide. And hemiretinal vein is actually occlusion of the whole upper quadrant venous system. Then these type of occlusion can be further subdivided as to whether the occlusion is ischemic, which means that there is a large area of retinal non-perfusion with a higher incidence of side effects or complications versus non-ischemic with a lower incidence of complications. And branch retinal vein occlusion is more common than central retinal vein occlusion. Branch retinal vein occlusion makes up about 80% of cases versus central retinal vein occlusion, which is about 20% of cases. So what is the pathogenesis of this central or branch retinal vein occlusion? And even though it's called a vein occlusion, it is actually an arterial disease. And the hypothesis is that the central retinal vein is occluded in the optic nerve behind the lamina cribosa, by the artery. Actually, atherosclerosis in the central retinal artery compresses the central retinal vein, and they share a common sheath behind the lamina cribrosa. So it's this atherosclerosis in the artery that pushes on the vein, produces thrombosis. There's other potential etiologies, including inflammation causing occlusion of the central retinal vein and anatomic variations in the lamina cribrosa. And this is supported in some cases by a higher incidence of central retinal vein occlusion in eyes that have glaucoma with abnormal optic nerves. It can also result from patients with hemodynamic disorders, elevated blood viscosity, and clotting disorders. So how about branch retinal vein occlusion? So similarly, this is thought to be primarily due to arterial disease, and the artery compresses the vein at the venous crossing. And you can see here where the artery and the vein cross, the retinal venous occlusion is distal to this. It can also be related to degenerative changes in the vascular walls and hematologic factors, again, poor blood flow, hyperviscosity, and clotting abnormalities. And we can see here that the branch retinal vein occlusion is less diffuse. If you consider the Blue Mountain Eye study to look at the epidemiology of retinal venous occlusion, the prevalence was about 1.6%, and it increases with age. It was about 0.7% in patients aged less than 60 versus up to 4.6% in patients over 80 years of age. When they looked at patients who had retinal venous occlusion, it was a BRVO in about 70% of eyes versus a CRVO in 25% of eyes, and it was bilateral in 5%, undermining again how important it is to really try and identify if there's any risk factors. So what are the risk factors for retinal venous occlusion? Let's go through these. Age, number one, as we just talked about, also glaucoma and increased intraocular pressure increases the risk for retinal venous occlusion. Also, systemic vascular disorders increase the risk of retinal vein occlusion, and these include the common causes: diabetes, hypertension, and atherosclerotic cardiovascular disease. Also, inflammatory and autoimmune diseases increase the risk for retinal vein occlusion, including systemic lupus. Hematologic abnormalities, hyperlipidemia, hyperviscosity syndromes, and coagulation abnormalities. And what about young people? There is a subset, and it's not very common, of younger patients who develop central retinal vein occlusion. And some of the risk factors found in these patients include hypercoagulability, hyperhomocystinuria, elevated anticardiolipin antibodies in these patients, and it's thought that a hypercoagulable or dehydrated state may contribute to central retinal vein occlusion in younger patients. So how do we make the diagnosis of retinal vein occlusion? It is typically a clinical diagnosis if patients are seen acutely. And the key factors are retinal veins are both dilated and tortuous. And this is so key that I make my fellows and residents say it 3 times so they don't forget that the retinal veins should be dilated and tortuous. Also, there should be retinal hemorrhages in either 2 quadrants for a branch retinal vein occlusion, 1 to 2 quadrants versus all 4 quadrants for central retinal vein occlusion. So those are the 2 big factors. The retinal veins are dilated and tortuous, and there's retinal hemorrhages. Other associated features can include macular edema, cotton wool spot, lipid exudate, vascular collaterals, regions of vascular non-perfusion, sheaths, vessels, and optic nerve swelling. We can see on the left a central retinal vein occlusion, and you can even tell on this, not on this like low dimensional view, that there's macular edema. Just the foveal details are not sharp. And on the right, same thing, we do not see the fovea well. There's hemorrhage in the fovea, and there's this nerve fiber layer pattern to the hemorrhage on the right. So how does imaging play a role in diagnosis and treatment of retinal vein occlusion? Well, color fundus photographs help to supplement the examination. Here we can see the hemorrhage that is above the superior horizontal meridian. And there's exudate that is streaming from the hemorrhage into the fovea, likely consistent with macular edema. Here's a red-free fundus photograph in a patient who also has macular degeneration. We can see in the left eye, there's some atrophy around the fovea. And in the right eye, there's this hemorrhage along the supratemporal arcade. The retinal vein is dilated and tortuous. We can see that is distal to where the retinal vein and the artery cross, and the retinal vein looks compressed in this region. So in the past, fluorescein angiography was really a gold standard to help us with diagnosis. And this is showing some of the findings in a patient who has a branch retinal vein occlusion. These include delayed filling of the veins, tortuous dilated veins, regions of retinal capillary non-perfusion. And as I said before, it's analyzing the amount of non-perfusion that helps us determine whether the venous occlusion is ischemic or non-ischemic and helps to prognosticate. Also, regions of leakage are seen, neovascularization of the retina, and ischemia. And if we look at this fluorescein and we follow it through the timer, you see on the bottom right how the retinal vein coming off the optic nerve is really abnormal in caliber. It looks like it's beaded. And if you follow it along, it looks like it's compressed by the artery at multiple locations. So this was the gold standard, but to do fluorescein angiography, that requires injection of a dye intravenously. And we usually follow the images up to 15, 20 minutes, sometimes less, to get these images. And there's a risk, of course, from injecting something intravenous, a very rare possible risk of anaphylaxis. So now we have this novel imaging technology that's really become available clinically in the last 5 years. And this is called OCT angiography. So it's a novel, non-invasive way to look at retinovascular and choroidal vascular flow. And this is showing a typical OCTA in a patient with retinal venous occlusion. And some of the findings that we'll see on OCTA are decreased vascular perfusion, venous loops, vessel tortuosity, collaterals, macular edema, increased foveal vascular zone. And here we can see, if we follow the top panel, that is the OCTA images in looking at specific slabs of the retina. So the upper left is looking at the superficial capillary plexus of the retina. Then the next one is the deep capillary plexus, and then the choroidal images. Below that's the en face OCT, and it comes with a regular structural OCT showing cystoid macular edema in the bottom images. So this shows the retinovascular anatomy of the eye, and you can see that there is a superficial vascular plexus in the eye and a deep vascular plexus. And what OCT angiography has shown us is that really the deep vascular plexus in eyes with retinal vein occlusion appears to be prominently affected. So let's go through a few cases. Here's OCTA in a patient with central retinal vein occlusion who did not have macular edema. On the left is total retinal projection. It looks at both the superficial and the deep vascular plexus in one view. We can see actually the foveal vascular zone in this eye is enlarged. The middle view is looking at the superficial vascular plexus only. And if you look below in the bottom of the middle view, you can see the segmentation lines of that OCT. And on the right, image C looks at the deep vascular plexus, and below it, you can see the segmentation line. And if you haven't looked at a lot of these, I can tell you that the deep vascular plexus in this eye has more prominent decreased vascular perfusion. Here's another way that we've looked at these images. On the left shows a fluorescein angiogram image, and on the right shows overlay of the OCTA images on top of the fluorescein images. And one thing to note is that fluorescein angiography injects dye, and the dye leaks over time and the images get blurry. But in OCTA, it doesn't show dynamic leakage. It shows a static image that can be segmented and manipulated. So you see on the right-hand side of the slide, those three images, the OCTA image is placed on top of the fluorescein, and the images are much crisper. Okay, and the middle one gives the entire OCTA of the entire retina. And on the right, you can see the OCTA of the deep capillary plexus overlaid on top of the fluorescein. And this foveal avascular zone is abnormally large. So we see better details. Here's another OCTA in a patient with a branch retinal vein occlusion. And we can see other features of BRVO and CRVO, including collateral vessels and vascular loops. And this is because over time, patients with BRVO and CRVO, the anatomy in their eye, other blood vessels try to compensate for the occlusion, and they develop these irregular blood vessels. This is another great way to look at it. This is a fluorescein angiogram, and multiple OCTA images were placed on top, overlaid onto the fluorescein angiogram. And we can see here that this is an inferotemporal branch retinal vein occlusion. So below the horizontal raphe, you can see that there's all these black areas of capillary non-perfusion. There's some vascular loops, irregular vascular tortuosity, and this very enlarged foveal avascular zone. How does this help us with treatment? So again, here's a patient who had macular edema. We can see in the top row of images, there is the OCTA image before treatment, showing on the right, the deep capillary plexus with these large cysts in the retina. And we can see the OCT image just below that showing macular edema. If we look at the bottom row of images, this is after anti-VEGF treatment. The macular edema has resolved, and we can see that there's better imaging and flow on the OCTA, but there's still an irregular foveal avascular zone. So here's another case, because I always like to use cases to illustrate my point. This is a patient who came in with an acute branch retinal vein occlusion. And I feel that, this tells us everything that we need to know, that it may not be necessary to do fluorescein angiograms in patients if you can't make the diagnosis clinically. We can see that there's irregular blood vessels on both sides of the foveal avascular zone with these irregular tortuous vessels. And there's also regions of capillary non-perfusion. In the upper right, the en face OCT, we can see these large cysts, which are also seen on the structural OCT down below, consistent with a branch retinal vein occlusion. So this patient was treated, and we can see the left prior to treatment, the images I just showed you, and on the right, after treatment, there are still abnormal blood vessels that exist around the fovea. And we can see the en face OCT, the middle row on the right shows that there's some residual exudate and hemorrhage. And on the bottom image, the macular edema is much improved with return of the foveal avascular zone, with return of the foveal depression. One other thing that's interesting about OCTA is that when this technology was initially became available clinically, we're only able to look at small segments of the retina, measuring 3 by 3 and 6 by 6 millimeters. But now that as technology has improved and our scanning speeds have increased, we're able to look at much wider views, 12 by 12, 15 by 15, and 15 by 8, and even able to mosaic multiple views. So this is a 12 by 12 image showing the irregular vessels on either side of the fovea and an enlarged foveal avascular zone. And you can see there's decreased perfusion, supratemporal, consistent with the supratemporal branch retinal vein occlusion. Here's another case I wanted to show you. This is a patient of mine. You can see here, supratemporal, there's irregular vasculature consistent with a branch retinal vein occlusion. And this patient had this wide field OCTA image on the left. There was no macular edema in the center, but when I scan where the yellow line is, I can see that there's some extrafoveal cystoid changes consistent with the picture on the right. So just to summarize this, OCTA, also known as OCT angiography, is a modality to non-invasively evaluate the retinal microvasculature. In eyes with retinal vein occlusion, there's a host of changes that we see, including decreased vascular perfusion, which is typically more evident in the deep retinal vascular plexus, especially in branch retinal vein occlusion. We also can see vascular looping, vessel tortuosity, collaterals, and increased foveal avascular zone size. There is a clinical utility for OCT angiography in diagnosis and following treatment in eyes with retinal vein occlusion and other retinal vascular diseases. And fluorescein angiography may not be necessary, which has some risk from intravenous dye injection and takes longer. So I want to kind of start things up for the second section. Where are we going with treatment for retinal vein occlusion? So I'm going to take us back a little bit in time to 2009. And at that time, the treatment of retinal vein occlusion was different than we have now. So that was just 11 years ago, 11, 12 years ago. And at that time, we had a natural history study called the Central Retinal Vein Occlusion, and it evaluated laser versus other modalities for central retinal vein. And it found that grid laser treatment reduced angiographic evidence of macular edema, but the visual benefit after 3 years was really minimal, and grid laser treatment was not recommended for central retinal vein occlusion. And at that time, there was no really recommended treatment for macular edema secondary to retinal vein occlusion, other than panretinal laser if neovascularization developed. Well, we have come a long way since this. We're in the year 2021. And Arshad is going to tell us about the 2 FDA-approved anti-VEGF therapies for CRVO, the off-label anti-VEGF therapy that is also available. There's also corticosteroid treatments available, and there's multiple novel new medications and delivery devices being assessed for retinal vein occlusion. So in 11 years, we have come really far in how we treat central retinal vein occlusion, and most of these modalities are also used for branch retinal vein occlusion. So I'm looking forward to hearing that. So let's go through the post-test clinical vignette. OCT. And the answer is OCT gives an optical biopsy of the retina. Let's see the results. What I will say is that if we go back, OCT uses light to produce retinal images. Aha, there we go. There's the results. And looks like the majority of people got that correct. So going through the answers, A is incorrect because OCT uses light. C, OCT does not require intravenous injection of dye. D, OCT has been used in many phase 3 pivotal studies to show results. So great job, everybody. Let's go on to question number 2. Which of the following is true about retinal vein occlusions? And I will tell you that the answer is C. It is the second most common cause of retinal vascular disorder in the elderly. Number 1 being diabetic retinopathy. And if we look at the other answers, it is not a common cause in young individuals. It is a common cause of retinal hemorrhages, and it does not require fluorescein angiography for diagnosis. And it looks like everybody got that correct. Great job. So I'm going to have my associate, Dr. Kanani, pop on. hello, and see if we have any questions about the pathophysiology, risk factors, imaging of retinal venous occlusion.
Great talk, Caroline. Amazing. You're a great presenter, I'll tell you. So I learned a lot about OCTA because you're an OCTA expert, and I am not a big OCTA user just because of how much time it takes and burden to the clinic. So I have a couple of questions for you before I start my talk. Is number one, when a patient presents with you, let's say with CRVO, the case you showed where you didn't have central macular edema, but you had cystic changes paracentrally. What do you tell that patient, and do you treat that patient or you observe that patient?
Well, that is a great question, Arshad. And that is a patient who has deferred treatment. He initially had macular edema that was just at the fovea, and he was symptomatic, and he had maybe 2 or 3 anti-VEGF injections. And subsequent to that, he has wanted observation. He is asymptomatic. Actually, I treated his retinal detachment in his other eye, and I lasered a tear in this eye. So at first I was a little hesitant to watch him closely. You know, I like to follow the clinical studies and give patients a little bit more of a loading dose. He'd only had 3 injections, but we agreed to close observation. And I've been following him for many years, every 3 to 4 months, and he is remained stable, and he's asymptomatic, and he defers injections. But typically, I would say that if it's within the fovea, a vascular zone, or if there's active exudation, I would definitely treat them. But this is a very reliable patient, and he really would prefer observation.
No, I think that's a really good point is, communication with the patient, and if they can come back and I have done that too, where you don't have central involvement with BRVO and CRVO, and then you bring them back in a month and now they have worsening edema and decreased vision, then you need treatment. And of course, I'm sure you're watching him for neovascularization to make sure that he doesn't get NV, so that he doesn't have a vitreous hemorrhage or some other complication. But I have another question is OCTA. So what is your flow for your clinic patients? I know, I have a OCTA machine that takes a little bit longer. It's the same machine that I use for OCT. So it clogs my clinic up. So what do you recommend as an OCTA expert in terms of what are the time points you get OCTA in a patient with retinal vein occlusion? It appears that you're not doing fluorescein angiography, which makes sense that if you already have the diagnosis, what are you seeing on fluorescein? I mean, I do it just to look for ischemia as well as neovascularization if I suspect any. But what is your flow? Do you do OCTA every time, or do you recommend doing it at baseline and maybe 3 or 6 months after? How does that work in your clinic?
So I totally understand what you're saying, but about clogging up the clinic, but that's why I feel like I've gotten past that point. And what I've done is we have done so many OCTAs in my clinic that our staff do them so relatively quickly now. It's really like the sort of thing, when you use it, it speeds up. So I would say that I use OCTA on all patients every visit with a retinal vein occlusion. They just come in, it just takes a couple moments longer than the standard OCT. And I also use it for most patients who have neovascular AMD. The one thing about OCTA is that, of course, it depends. The images are made by imaging the retina multiple times quickly and then digitally subtracting everything that is stationary in the image. So what you're imaging is really movement of red blood cells. It moves so quickly. So if you have a patient who has really poor vision and can't fixate or can't cooperate, don't do an OCTA. But Arshad, do you know what I tell my photographers? I say, if you can't get a good image within 2 minutes, just don't do it. Because if a patient can't see or cooperate in the first 2 minutes, it's like with my children. The more you push sometimes, the less success you have. And sometimes I'll just focus on the eye that has the pathology. I'll say, just image one eye. Patients get really exhausted and the next time I'll write in my note, just do OCTA in the eye that has the pathology next time. I don't think we have to do both eyes every time. So I don't think it takes me longer, but I have seen a patient have anaphylaxis from fluorescein angiography.
Yeah.
And it was about 16 years into my practice, but I've never been a huge fluorescein advocate, although I do think it's good to look for peripheral ischemia. So I feel like if I don't have to do it, especially in elderly patients, I'd rather not. I mean, the real thing with imaging is if we see a patient and we know a patient clinically has like the color pictures I was showing, a CRVO or BRVO, we know what it is. We just really need to look for edema and neovascularization. So sometimes imaging, especially fluorescein, can help us if we're seeing patients like a year after they've had a vein occlusion, if some of the signs have resolved. If we're seeing a patient who's more chronic, I think that's when fluorescein can help us. Or if you're seeing a patient with vision loss of unknown etiology, you might do a fluorescein and say, oh, this patient might have had a vein occlusion before, or even sometimes a patient with geographic atrophy might have had a vein occlusion causing that. So I think that's where fluorescein really is more helpful.
No, I think those are great points, Carol. And I think the bottom line is that, we have to do testing that helps us understand the disease, right? We don't do testing just for the sake of it. So it seems like you have used OCTA very nicely to try to cut down fluorescein. And, I've seen some anaphylaxis, and those are not pretty when you take your, EpiPen out and call 911. We had several cases suddenly, and we sent the dye to FDA, and they didn't find anything, but we had several cases. So I remember, I don't want to be in that situation again.
Right.
For me, my OCTA machine is the same. So you probably have a freestanding OCTA, right? Or is the same machine you're getting OCT on?
It's the same machine. We have, I don't know if we should say brands, but we have the OptView and the Zeiss machine. And so, yeah, if, for example, they couldn't do OCTA, we could just do a standard OCT. I'll tell them to start with the OCTA first, because that's the most exhausting thing. So do that first.
Yeah.
And with COVID, sometimes I'll even, if I know a patient, if it's not a new patient, and I'll image them even before they see the tech, before they get really tired. I've just been trying to change that flow, and it seems to work for a lot of patients. There's two questions in the chat that I want to try and get to quickly. One was, do you recommend gonioscopy at every follow-up visit to look for neovascularization of the angle? Well, that was recommended in the central retinal vein occlusion study, especially in eyes that are ischemic. They do recommend that at every single visit. And I think it's pretty easy to put the 4-mirror handheld.
Do you do it, Caroline? I don't do it. I treat them with anti-VEGF, and I'm confident that the NVE is gone.
Yes.
Right?
I say I do it the first time I see them, and I'll do it a few times after. And sometimes I'll have the residents and fellow do it because I like them to learn how to do it. But I think that if it's non-ischemic, it's probably not clinically that useful. But I do use the 4-mirror handheld lens. I don't use the lens that requires gonio. How do you manage the great amount of computer memory required for OCTA? We have a really interesting system, but we have everything backed up. And that is because we didn't have everything backed up in the beginning, and there was a computer glitch. So we do have like a double hard drive inserted in. And I think that I ask our photographers, don't take pictures if they're not good, or just trash them. Because if it's not a good picture, we don't want it using up our memory. And then the last question is, are you seeing COVID-related retinal vein occlusions? It's really hard to say when we think about the probably millions of people that have had COVID. Is this just the normal amount of retinal vein occlusions that we see, or that people aren't coming in, or is this related to COVID? Or some people have thought that maybe it's related to the vaccine. I don't feel like I'm seeing more retinal vein occlusions related to COVID or the vaccine. But I have seen, and we did write a letter to the editor about this, we saw a patient with secondary effects from COVID, from coughing, a patient with Valsalva retinopathy. So I've actually done some vitreous cultures in patients who are COVID positive that I operated on, and
Wow.
they were sent to look for COVID and they were negative. So I'm not sure that COVID really affects most people, in the eye, or if it gets into the vitreous. Hard to say.
Great. Thank you for answering those, Caroline. I think
you.
great job again. Excellent talk. So I'm gonna get started on my talk now, which is talking about the trials related to retinal vein occlusion. And I'm just trying to share my screen. Did you stop sharing your screen?
I did.
There we go. Okay, perfect. Can you see the slides, Caroline?
I can. Great. I'm excited to learn about some new treatments.
Great. Thank you, Caroline, so much. So my job today is to make sure that we cover the agents that have been approved for treatment for RVO, including VEGF, anti-VEGF inhibitor, as well as steroids, and then how we can use the data from the trials and then use them to individualize the treatment for our patients with retinal vein occlusion. Here are my financial disclosures. So this is a pre-test vignette. You're going to see the answer. We're going to cover it at the end, but this vignette sets the stage for the talk. A 68-year-old female presents with slow vision loss in the right eye. Complete eye exam shows a branch retinal vein occlusion. Which of the following is approved by the FDA for the treatment for BRVO? So here are your answers. A, KSI 301, B, faricimab, C, aflibercept, and 4, brolucizumab. So I'll give you about 30 seconds to answer this. Again, you can see it on your screen. Which of the following agents or which of the following agent is approved by US FDA for the treatment of BRVO? And we're going to discuss, obviously, this at the end. So let's go to the next vignette here. Here we go. This is the second vignette for this talk and fourth vignette for the whole presentation. The Vibrant study with aflibercept was designed to evaluate patients with what condition? A, CRVO, B, BRVO, C, diabetic macular edema, and D, neovascular age-related macular degeneration. So let's give a few seconds for you to pick the answer here. The Vibrant study with aflibercept was designed to evaluate patients with what condition? Okay, great. So now let's get into the presentations. And again, we are gonna discuss these questions at the end. So as Caroline said, we have come a long way in the last 10 to 12 years in terms of treatment for retinal vein occlusion. We have tried several different strategies. We have tried lasers, we have tried thrombolysis, we have tried, shethectomy. We have tried a lot of things to see if we can help these patients with the retinal vein occlusion, not lose vision. But obviously, the game-changing stuff has been anti-VEGF agents with the approval of ranibizumab, followed by aflibercept, and we're going to cover those studies, as well as approval of dexamethasone implant for treatment of retinal vein occlusion. So the rationale for VEGF inhibitors, Caroline covered really nicely the pathophysiology of retinal vein occlusions. So the idea here is that VEGF is an endothelial cell specific angiogenic factor, and it relaxes endothelial cell junctions to increase vascular permeability. So you have patients who have retinal vein occlusions, they have relaxation of these junctions, they start to leak fluid in the retina, leading to macular edema, which leads to vision loss. And, simple enough, you block VEGF, and that effect leads to decreased vascular permeability with resolution of macular edema, leading to better or improvement in visual acuity. Now, one thing to keep in mind, we treat a lot of retinal vascular diseases. Some of them are, longer term diseases, especially like if you're treating macular neovascularization for neovascular MD, we certainly know majority of those patients are lifetime diseases. Here with RVO, the hope is that the body will heal, this condition over time. And the hope is that Some patients need very few treatments depending on what their age is, compared to older patients may need long-term treatment. So I tell my patients about the fact that hopefully they're not going to be on lifelong treatment for this condition. So let's go to ranibizumab, the first FDA-approved agent for retinal vein occlusion, both retinal BRVO as well as CRVO. Obviously, we know the agent is also approved for neovascular AMD, diabetic macular edema, diabetic retinopathy, myopic CNV, and it's an in-clinic intravitreal injection. Aflibercept is the other agent approved for BRVO as well as CRVO, also for wet AMD, RVO, DME, and diabetic retinopathy, again, in-clinic intravitreal injection. And bevacizumab is an off-label drug. It's not approved for ocular indications. It's approved for cancers, but it's utilized because of low cost and availability and coverage. So, you know, it's off-label, but it's also used for retinal vascular diseases. So now let's look at what led to the approval of these agents for treatment for RVO. Bravo was a study with ranibizumab for BRVO. Cruise was a CRVO study with ranibizumab. Vibrant looked at BRVO patients treated with aflibercept, and then Copernicus and Galileo looked at CRVO patients, and Geneva looked at intravitreal dexamethasone. So it was not a pivotal anti-VEGF study, but a steroid study. So let's look at Bravo. Bravo is a multi-center randomized double-masked sham injection control phase 3 trial with ranibizumab, and looking at efficacy and safety of ranibizumab in patients with BRVO. We had 3 different arms in there: 0.3 milligram of ranibizumab, 0.5 milligram of ranibizumab, and an arm with sham injections. So here you can see the study design is 1:1:1 randomization. Patients were treated monthly, and the primary endpoint was at week 24. After the primary endpoint, patients were treated as needed based on specific pre-specified visual acuity and OCT criteria, as you can see on bottom right, and were then followed. If you look at mean change from baseline for BCVA over time to month 12, you can see there's significant improvement of visual acuity in patients who were treated with ranibizumab. And you can see that the primary endpoint of the study at 6 months, the studies obviously met the primary endpoint, where patients treated with ranibizumab had more than double visual acuity gains compared to patients who received sham. Now, of course, after the 6 months, you can see there was some benefit of patients who were in sham before, after they get ranibizumab, where they did have improvement in visual acuity, but they never caught up to the patients that were treated initially with ranibizumab. Here you can see proportion of subjects who gained 15 letters or more from baseline to month 12. And again, you can see significant number of patients with treatment gain that, and you can see that number is over double compared to sham. When you look at changes in central thickness on OCT, you can see there's significant decrease in patients who are treated with ranibizumab. The interesting thing to note is that most of the impact you're actually getting within the first 2 or 3 injections. You can see how robust improvement happens after the first injection, and then we have to stabilize that with multiple other injections. Interesting thing is in the PRN phase, you can see there is some increase in CST because of a decreased number of injections. But again, overall patients did really well. Patient did improve in the sham arm. As you can see, there is decrease over time. And that's what we did before we had treatment. But again, the improvement is not significant compared to one with intravitreal injections. And then you can see after they were switched to ranibizumab, you have significant improvement after 6 months. Cruise is a study looking at CRVO, again, a sham control trial with 3 different arms, 0.3, 0.5, or sham injections in this trial. You can see the study design here, very similar to the Bravo trial, and you can see the primary endpoint at 6 months of treatment. And then again, patients were followed PRN for 12 months in this trial. Again, significant improvement in visual acuity after the first injection, and it continued to improve over time at primary endpoint compared to sham, where patients actually did really poorly, as you can see. So it appears that patients with CRVO, the natural history is much worse than BRVO, as we know. And you can see here that there is minimal to no improvement over time in these patients after they were switched to ranibizumab, you can see there is improvement, but they never caught up to the patients who were initially treated, highlighting the need for treating edema sooner than later in this condition. Also, again, the number of patients with who gained 15 letters of vision, significantly high number, more than double, again, and with patients who were treated compared to patients who were not treated. And again, even after treatment after 6 months in the sham group, they never caught up to the patients who were initially treated. You can see there's more fluctuations after the primary endpoint in the PRN phase in CRVO patients compared to BRVO patients, showing that patients who have CRVO, they have much more propensity for leakage and need more frequent injections. Again, significant decrease in CFT as we saw in the BRVO patients. After the first injection, you get great efficacy, and the goal is to control that. Again, in the sham group, after they were switched, you can see that there was some improvement also significantly in CFT. Now, those were the ranibizumab trials. Now look at aflibercept trial. The Vibrant study looked at patients with BRVO. In this study, patients were randomized 1-to-1 to either monthly aflibercept or laser, as Caroline covered in her talk, that, you know, BRVO, the initial treatment before the agents came out was laser. The primary endpoint was also at week 24 in this study. And then again, patients were treated every 4 to 8 weeks in the 6 months phase after the primary endpoint in the aflibercept group. And then patients in the laser group were switched to every 4-week aflibercept. So here you can see percent of patients gaining 15 letters or more at primary endpoint. You can see again the consistent story of more than double with anti-VEGF treatment, compare here with laser. And you can see also at week 52, at 1 year, that the percent of patients who were gaining vision with laser arm increased because they were receiving aflibercept after the primary endpoint at 6 months. Here's the mean change from BCVA from baseline. You can see significant improvements with the aflibercept injection compared to laser. Number of letters, 17 letter gain compared to 6.9 letters in the laser group. And then that gain continued with aflibercept, every 8 weeks or so. If needed, and then patients who were switched to aflibercept after the laser also gained vision, really showing the efficacy of aflibercept in patients with branch retinal vein occlusion. And you can see the CRT, and you can see there's significant reduction in CRT over time in patients. And you can see the same thing you saw in Bravo, that there's significant reduction in CRT after the first injection in patients treated with aflibercept. And then there's significant reduction in CRT after the primary endpoint in the laser group because they were treated with aflibercept, again, showing how aflibercept works great for these patients with branch retinal vein occlusion. Looking at the CRVO studies, the Galileo and Copernicus studies for CRVO with aflibercept, these are also studies looking at aflibercept every month versus sham in this case, so no laser. And the reason is, as Caroline presented, that based on the studies, laser did not make a difference in patients with CRVO unless they have neovascularization. So it was not standard of care. And again, when these studies were launched, we didn't have any treatment for CRVOs. That's why the sham was allowed. Going forward in the ongoing trials, as I'll present, is actually not allowed because the comparator arm will be a treatment arm because we have multiple treatment that are approved for this condition. So again, primary endpoint at week 24. And then in Copernicus, you can see all eligible patients to receive monthly aflibercept or PRN basis. In Galileo, again, same thing. They receive monthly aflibercept or PRN. And then the treatment was continued to week 52, then every 3 months to week 100. And here you can see the study schedule with primary endpoint at week 24. Again, proportion of patients who gain 15 letters of vision, significant number, showing actually more than 3 times compared to sham at week 24 and almost double at week 52. And again, the patients who were in sham were switched to aflibercept. That's why they benefit from the treatment. And this is for Galileo. Again, similar story here, where patients treated with aflibercept had significant visual acuity improvements. This is the vision improvement. You can see robust improvement after first injection in both trials with peak vision with more than 3 lines of visual acuity gains and maintenance of it based on the treatment. And then after the primary endpoint in the sham group, you can see there is some improvement in the Copernicus arm where they were able to receive aflibercept. And then mean change in CRT, again, significant improvement with aflibercept in both studies. And then the extension study looked at after primary endpoint, how these patients do long-term. And there was PRN treatment criteria every 3 months from 52 weeks to 100 weeks in these patients also. And then you can see the distribution of injections, proportion of patients that were needing injections from week 24 to week 100. And then the proportion of patients who gained 15 letters at week 24, and then ones who gain at week 100. And then long-term visual acuity, you can see that there's significant improvement in visual acuity and maintenance of visual acuity over time. And then long-term mean change in CRT again in the Copernicus trial. And the proportion of patients with dry retina, you can see if you treat every month, you have about 75% of patients with dry retina. If you go to PRN, you can see there's actually a decrease at week 52 and then week 100 because patients are getting less injection, really showing the high need that most patients have with CRVO. In conclusion, the visual acuity and anatomic improvement observed at the end of the fixed dosing period were diminished after changing to PRN dosing. PRN dosing with infrequent monitoring led to further decline in visual acuity. Again, aflibercept works really, really well for both PRVO and CRVO. We just need to make sure that we monitor these patients and treat them as aggressively as we can so that we kind of have maintenance of visual acuity over time and not decline over time. Now let's look at dexamethasone. The Geneva study looked at patients with retinal vein occlusion. This was a study ran by Allergan, and it compared 2 doses of dexamethasone, the 350 and 700 micrograms. This is an intravitreal injection, and this is a 6-month mass study with 6 months follow-up. And then second 6 months were open label where patients were switched from sham to active medication. We have all seen the dexamethasone implant. It's injected in the eye and it stays in the eye for up to 6 months. This is a trial design. I don't want to spend too much time on it. All I can tell you, it's a very large trial. You can see 1,267 patients were randomized 1:1 in these groups. And then and the numbers, of course, decrease over time. But overall, this is a very large trial looking at this condition. And you can see mean change in BCVA from baseline. And you can see that patients who were treated with dexamethasone did really well by day 30 and day 60 compared to patients who received sham. And then that effect went away or decreased over time at day 180. And then they were treated again with dexamethasone, and they were able to get back to where they were initially, showing that patients with RVO got significant improvement because of dexamethasone injection. And you can see in the sham group, after day 180, you can see the blue line there, that after they received that, they did improve, but they never caught up to the improvements seen with initial injection groups. So again, even anti-VEGF and steroid, the goal is to treat early because you may not get the benefit, as much benefit, if you wait too long. These are patients with 15-letter gains from baseline, and you can see that patients treated with dexamethasone had significant improvements compared to sham. And then the sham patients improved after they received dexamethasone after the primary endpoint. And then this is the mean change from baseline, retreated and single treated population. And you can see the visual acuity here. And then this is OCT change in mean values from baseline. And you can see there is significant decrease especially with 700 microgram of dexamethasone, shown in orange brown here. And the blue is the 350, and sham is gray. So you can see significant improvement with treatment here. Now, of course, it's a steroid. We need to pay attention to the adverse events. So the adverse events of IOP increases, as well as cataract formation, are something we pay attention to. And you can see the IOP changes here, and you can see they peaked at day 60 and then returned to baseline levels at day 180, really kind of correlating with the efficacy we saw in this trial in terms of improvement. And then cataract extractions, you can see that the rates were low in the study eye, but of course, slightly higher in patients who were treated with steroids compared to the non-study eye in those patients. So now let's look at some more newer agents. KSI 301 is the antibody biopolymer conjugate. We have seen the data from phase 1B trial, which is looking at neovascular AMD, DME, as well as RVO. Since the talk is about RVO, I'm going to cover some of that data. Again, it's an antibody, which is VEGF-A inhibition, inhibitor attached to a large biopolymer, really showing design for durability in the eye, kind of next generation anti-VEGF agent. You can see in these naive patients with retinal vein occlusion with 3 loading doses, you have significant improvement in these patients with only 1.7 individualized doses after the 3 loading doses. Of course, the numbers are small, BRVO 19, CRVO 15, but this study was designed to get a signal about efficacy, and you can see only 4.17 mean injections with significant maintenance of improvement, showing the durability of this molecule. And here it is highlighted. You can see 4.7 mean injections, and 72% of patients receive only 2 or fewer retreatments in first year, really showing that it's a variable disease. But with KSI 301, we can control it with less injections. And then you can see 66% of patients who are on a 6-month or longer interval, treatment-free interval at year 1 after the 3 loading doses with KSI 301. And then here you can see the different groups of patients with a different treatment interval. This is a case from phase 1B. Can we really control CRVO with 2 loading doses? Well, this is an example of a patient who received KSI 301 in the 1B trial, and you can see at week 24, there was 23 letter gains. And after the second injection at week 4, and after the second injection at week 8, you can see there's no disease activity and there's significant visual acuity improvement from baseline. So the Beacon study, it's a pivotal trial with KSI 301. It's a prospective study that's ongoing to look at patients with BRVO, HRVO, as well as CRVO. And approximately 550 subjects will be enrolled. The study is recruiting currently, and KSI 301, 5 milligram versus aflibercept 2 milligram. It will be randomized 1-to-1, and we await data to see how patients do. This is a non-inferiority trial design, and KSI will be dosed every 8 weeks after the 2 monthly injections versus aflibercept every month, really trying to tease out the durability of this molecule to see if it's non-inferior to aflibercept. And you can see the secondary objectives on the right. Again, the study is ongoing, and this is the study design where after the primary endpoint, we go into the individualized treatment plus sham period for these patients. The other ongoing trials are brolucizumab trials, Raptor study looking at BRVO, Raven looking at CRVO. In both trials, the comparator arm is monthly aflibercept, and the primary endpoint is at week 24, just like all other RVO trials. Patient receive monthly brolucizumab versus monthly aflibercept for the 6 months. After that, they go into PRN phase where the disease activity is done and patients receive treatment if they need. In faricimab, Peloton and Camino trial, again, monthly faricimab compared to monthly aflibercept, primary endpoint of week 24. Again, non-inferiority trial design for these trials to get approval for brolucizumab and faricimab for indications of retinal vein occlusion. So in conclusion, anti-VEGF agents are first-line treatment for patients with BRVO, HRVO, as well as CRVO. Frequent injections are needed, though, to maintain visual acuity and OCT improvements. As we saw when patients went into PRN phase with decreased number of injections, we did have some visual acuity as well, loss, as well as increase in central retinal thickness. Aflibercept, ranibizumab are FDA approved for it. Bevacizumab is off-label an agent, and they all result in significant improvement in visual acuity. Of course, we did not cover bevacizumab here because it's an off-label drug. And then the unmet need is still exists that patients need frequent injections, so we need more durable agents, and hence the trials are ongoing for KSI 301, brolucizumab, and faricimab to see if we can decrease the treatment burden for our patients with retinal vein occlusion while still maintaining visual acuity and the benefits on CST. So let's get back to the vignettes we had before. Hopefully all of you will get all the answers correct now. because Caroline got all hers correct. So you need to make sure I get mine correct or I look bad here. So a 68-year-old female presents with slow vision loss in the right eye. Complete eye exam shows a branch retinal vein occlusion. Which of the following is approved by the US FDA for the treatment for BRVO? So please go ahead and answer. Your choices are KSI 301, faricimab, aflibercept, and brolucizumab. We'll give you about 30 seconds to answer this. All right, let's see the answers. All right, close enough. So we got 75% correct. So aflibercept is approved by US FDA for the treatment for BRVO. Remember, the trials of KSI 301, faricimab, and brolucizumab are actually ongoing. We don't have data yet. We don't have approval yet. We only have 2 FDA-approved agents, aflibercept as well as ranibizumab. Let's go to the next question now. Let's see, here we go. The Vibrant study with aflibercept was designed to evaluate patients with what condition? CRVO, BRVO, DME, and neovascular AMD. Let's go ahead and answer. Please, about 30 seconds or so to answer this question. So Vibrant study with aflibercept looked for what indication for treatment in patients, and is it CRVO, BRVO, DME, or neovascular AMD? Okay, let's look at the answers. All right, 62% got that correct, that the Vibrant study looked at BRVO, and that's the right answer. CRVO was Copernicus and Galileo, and DME obviously were Vivid and Vista trial, and AMD was View 1 and View 2 studies. Thank you for answering that. It seems like Caroline is a better teacher than I am. I still want you to thank you for your attention, and I'd love Caroline to come back on camera so we can have some discussion. And of course, Professor Baumal had a better success than I did, or maybe my questions were too hard. I don't know.
Yeah, my questions were easier, Arshad. Come on, that's hands down. So, I have some questions for you, but we have a question from the chat. And it's a great question because it talks about when would you consider doing PRP for CRVO patients? And it also, it calls a little bit of attention to, in 2009, when in the early 2000s, we would treat CRVO and BRVO differently. So I'm going to also ask you, do you approach these diseases differently? When do you consider laser versus injection? What's your first line? Tell us. I've been to your office. I've seen Dr. Kanani at work, and he is a very skilled multitasker. His office is busy, has amazing patients, and in Nevada, where there's a beautiful background and of mountains. So how do you approach your patients with BRVO, CRVO, and when do you laser?
I think that's an excellent question in chat, and thank you for your kind words. And I tell you, now it's so easy. We have great anti-VEGF agents. We have aflibercept and ranibizumab that are FDA approved. So my initial first line, as I said, is to treat these patients aggressively on a monthly basis until the disease is controlled. And the trials give us the data, obviously, that in the PRN phase, patients can lose vision or have macular edema recurrence if you stop treatment. So I do mainly the treat and extend approach in this cases too, where I would dry the retina with monthly injections and then try to extend by 2 weeks. I don't go 4 weeks because, as you know, RVO, you can have recurrent edema very quickly. And that's why we want to watch these patients carefully. Of course, CRVO are harder to treat, especially ischemic CRVO, where you may not get improvement as fast as you get in BRVO. Of course, in the trials, most of them, both of them are included, but personal experience that ischemic CRVOs are hard and visual acuity benefit could be less because of thinning of the retina or the loss of photoreceptors. So anti-VEGF are first line, but let's say I'm doing treatment and patient develop neovascularization, or I have a patient with retinal vein occlusion that is not getting treatment, does not have macular edema, but gets peripheral neovascularization. In that case, instead of just giving them injections to control neovascularization, I would use laser at that time. So the laser is a tool in our toolbox, but it's not primary treatment. And of course, if anti-VEGFs don't work, we talk about steroid. You introduce steroids in your treatment algorithm, but of course you have cataracts and IOP to watch out for. So I think it's good to have options, but really amazing results with anti-VEGF agents in these patients. We both practiced before they were approved. Anti-VEGF agents were approved, and we saw those patients lost vision over time, and we couldn't do anything. And here, majority of the patients actually do really, really well. So
you're so right. Sometimes I'll see a patient and they'll come in and they'll have a lot of blood in the eye, awful edema, awful exudate, and be very hard. I'll have to treat them monthly that's not common because most people do better than that. But even, you treat them aggressively, and sometimes I'm surprised at how much vision they get back. So
yeah,
even if it's ischemic, so I do think that the medications we have are good. The only one thing is their durability, but that's another conversation. I have another question for you. And this is a good question because it does relate to the old days. Do you treat macular edema associated with vein occlusion with the first presentation, or do you observe first? And that question probably relates to before we had anti-VEGFs, if someone would come in with a branch retinal vein occlusion and macular edema, about 30% of those patients might get better on their own. So we would watch for 3 months before doing laser, because laser is kind of destructive. So how would you answer that question nowadays?
Oh, you just go straight to anti-VEGF agents. I mean, there's no question how efficacious they are and how good they work. And we saw that patients who actually you wait too long don't gain vision, as we saw in all the trials, that patients who were in the sham group or laser group for 6 months, once they were switched to treatment, they never gained the vision because of chronic macular edema and the damage to the retina. So absolutely, we see them. So of course, if you are not a retina specialist, you're an optometrist, you're a general ophthalmologist, you come in and you say, I have a patient with BRVO or CRVO, you refer to retina as soon as you can. They don't need to be treated that day, but usually within a week or so should be seen and treated so we can get maximum visual acuity gains in those patients. So I'm treating them as soon as I'm seeing them, or I'm putting them in clinical trials with a more durable or possible more durable agents with the ongoing trials. As you know, we are participating in all 3 of them that I mentioned.
I agree with you. I think the benefits of treating outweigh the risks. I mean, on occasion, there might be someone I see who the vein occlusion isn't that bad, or their vision's good, and they might say, I'd like to be observed for 3 to 4 weeks, and I'll be like, okay. Or if it's a vein occlusion in a young patient, because often those can get better on their own, but I really will watch them very, very closely. Otherwise, I think the benefit of treatment outweighs the risks.
I think you bring a really good point, Caroline. I think that if I have a young patient with a few cysts in the macula and 20/20 vision, younger patients are afraid of injections, they're freaking out. So I actually do the same. I watch them carefully, but I do tell them and you tell me your experience. I mean, a lot of young patients may need 1 or 2 injections and then they recover because, their body can heal the condition much better than compared to a 85 or 90-year-old patient. So I tell them that, hey, we can watch it, come back in 3 or 4 weeks. If it gets worse, we'll give you an injection. More than likely, you'll need 1 or 2 or maybe 3 injections, and you're going to be okay. And that's been the case. So I agree with you. I think it's all about risk and benefits, right? So if you have a 20/20 visual acuity and you have a few cysts in the macula, I'm totally okay waiting. But I'm not okay waiting when you're 20/40 with central thickness of 400 micron with glowing, like a lot of edema, and trying to hope that that gets better. I mean, if anything, anti-VEGFs help them, in my opinion, like get through the course faster, where the vessels actually heal. And what I've seen is, in younger patients, 1 or 2 injections are good enough.
Right. So that brings up a really good point. We sort of pull the whole clinical scenario together. I mean, it's not just, we're treating not just based on OCT, but really based on vision and a lot of patient factors, acceptability, age, how reliable they are to return for follow-up. All those things play a role in the decision-making. Another question here, are you doing any systemic workup in your retinal vein occlusion patients? I'll let you take that one.
Yeah, so if I have a patient that is young, does not have hypertension, does not have glaucoma, does not have any other risk factors, absolutely, I'm doing a workup for hypercoagulable state. And we did. I mean, in my training, there was a medical student that had a vein occlusion, which surprised all of us. And, we did the workup and had factor V deficiency. So I think, it depends on the age. I don't do workup patients above 65 years of age, usually less than 65. Now, if let's say they're 60 and they have history of hypertension or they have history of glaucoma, then obviously, I talk to them about workup, but I know what caused the vein occlusion is likely glaucoma or hypertension. So I do offer it, but I'm not pushing for it. But absolutely, a younger patient that does not have any comorbidity, we need to make sure that we do the workup so we catch any systemic issues sooner than them causing any other adverse events in addition to the vein occlusion. I don't know, Caroline, what do you do? What is your workup?
Well, Arshad, I think the key thing in this is, what do you define as a younger patient? Now, be careful, okay? Be careful.
A patient younger than you and I. A 25-year-old.
Yeah, okay. So it's interesting. Young patients used to be defined as under 50, and now it might be under 60 is a young patient. Yep. It's changed a little bit because people are healthier and living longer. I think that certainly anyone under 50, I would work up. But I would also take a medical history, like if someone was on the younger side, but they're smoker, high blood pressure, cardiovascular risk factors. I think that's the most likely etiology, yep. Especially, the inflammatory things to happen more in women, when people have a retinal vein occlusion in like a patient under 40, we also sometimes give that a different name called papillophlebitis. But I do think it's important to look for risk factors in those patients. So if it's a typical, 80-year-old with hypertension and it looks like a vein occlusion, it's a vein occlusion. So it's only
that's a really good point. So I think one thing I look for in young female is birth control, because you can get, thrombus formation from birth control. So that history also is important. So I agree. I think those are really, really good points.
So another question, which I know you're an expert on, why, and it takes us a little bit out of vein occlusion, but it's related. Why are so many retina specialists watching juxtafoveal diabetic macular edema instead of treating on first presentation?
I think that's outside the scope of this, but I think it's an interesting question. And I think we can relate that the macular edema with RVO gets worse really, really fast, and it will continue to get worse if you don't treat it in majority of the patients. Diabetic macular edema is a different disease. It's a localized area of a microaneurysm that's leaking over time. And based on the recent DRCR network trial, patients who got with good visual acuity, who got treatment or no treatment or got laser, the outcomes were pretty similar. So unless patients are getting vision loss from the edema, and if of course non-central, they may not, I usually watch it or consider focal laser. But that's a good question. I think we need to differentiate the retinal vascular diseases. Diabetic retinopathy is a very different disease than retinal vein occlusion. As you showed really nicely, Caroline, the images, there's significantly larger areas of damage. There's significant more ischemia in acute vein occlusions compared to slow ongoing diabetic macular edema. Of course, if they had proliferative diabetic retinopathy, they'll need a treatment sooner if they had in addition to the DME. But I think That's a really good question.
I think, and you hit on exactly what I was thinking, and that's why I brought this question up. I think diabetic macular edema is typically, not always, a more chronic thing that slowly builds up over time. And it's really based on the DRCR net recent publication that people are watching more. I think we were a little more prone to treat before, like right away. And there's still plenty of people who treat right away. But the patients are typically younger who are diabetic. It's a chronic disease. We always want to encourage our patients to control their risk factors versus retinal vein occlusion. Older patients, they can't always control their disease better to make things better. So just all those factors play a role. And in the end, we're treating patients, we're not just treating their OCT, we're treating their symptoms and trying to get them systemically to the right place where they should be.
That's very nice coming from an OCT expert. I thought you just treat OCTs and not patients.
Well, I treat both.
No, I know you're very good at examining the patient.
Try to think of both.
Getting your fellows to do an exam before they look at OCT, so you can learn. But I agree. I think, that's the struggle is OCT. It provides such great images. When does exam come in? And exam actually comes in very crucial for looking at NVE and as you said, gonioscopy and neovascularization and whatnot. So it's great. I think we need to treat the patient. I tell my patients the same thing. I don't treat the scan, I treat you. So if you're not having any symptoms, I'm okay observing you.
Right. I have another question here. It might relate a bit to imaging. Do ischemic central retinal vein occlusions always have an RAPD? Which is, the answer is no. But from the imaging point of view, we have definitions of ischemia for central retinal vein occlusions and branch retinal vein occlusions. And these are based on fluorescein angiography. But they're actually definitions that could stand to be a little bit revised now that we have wide field angiography. And even now that we have wide field OCTA, might help us better define what the area of non-perfusion is to cause the definition of ischemia. And I think this is going to be, machine learning is really going to help us with this, look at this better and be able to measure these areas better. And that will help stratify who needs laser and who needs anti-VEGF. We're not there yet, but we might be there in our lifetimes where a machine can measure ischemia even better than us and tell us this patient needs laser plus this, or this patient needs this. So they don't always have it, but those definitions might be reassessed in the next decade.
No, I think those are great points. And I think, machine learning and AI will play a big role in how we manage patients as well as remote monitoring with home OCT, as well as apps for visual acuity and other things. And I think as we go through it, I think the frustration is these patients have to come in frequently. And what can we do to decrease the burden and really bring them in when they need treatment? So that's why I think diagnosing initially with imaging and AI, as well as monitoring, I think would be a big deal. And as I said, I think we have better agents coming. You see faricimab showed positive phase 3 data in neovascular AMD and DME. The RVO trials are ongoing. Brolucizumab, shown the positive data in neovascular AMD and DME. And, KSI 301, pretty strong phase 1B data that with all ongoing trials. So we'll see where we end up. But I think it's exciting times that we saw patients suffering from these diseases and losing vision over time. And all we could do is burn the retina with laser. And now we can actually reverse most of these conditions and end up with better visual acuity in these patients. So yeah, it's very exciting times. I have a question for you. When do you utilize steroids in your practice in patients with retinal vein occlusion? And does age come into play, how fast you go into using steroids?
So I have a lot of familiarity using steroids for retinal vein occlusion and for diabetes at Tufts. One of our fellows in early 2000 was like, hey, we should inject steroids for diabetes. And we started to do that. And, it has very effective for these disorders. I would say that it is my second mechanism after anti-VEGF. I usually will give someone anti-VEGF injections, hoping that works. But there are occasions where retinal vein occlusion, we know there's an inflammatory factor to it. So usually if patient wants something where they don't want to come in as often, the sustained release delivery with steroid device usually lasts 3 to 4 months. So I might use in those occasions. But the one thing I want to make sure is that the patient does not have glaucoma before I use it.
A lot of patients with RVO do. That's the risk factor for RVO. So I think unless, I mean, I guess I have a few patients, Caroline, if they already have a tube in place. So if they already have a glaucoma shunt and they have a vein occlusion, then I'm much more inclined to use steroids because I know that the pressure won't go up because of the tube in the eye.
Right.
Trabeculectomy, yep.
Exactly. So I have quite a few patients like that too. I mean, I think that if you use steroids in someone with glaucoma, they need to be informed that the drops might need to be changed, and there is a risk that, you know, they might need incisional surgery. But if they've already had incisional surgery, it certainly helps. So I use it mostly as my second line, unless someone is anti-VEGF responsive. And what I'll do often is I will, if I think that a patient's not responding to the anti-VEGF medicine, I will give them an injection and I'll see them within a week and repeat the OCT in the exam. And usually if they show, you know, if they don't show any response within a week, I'll deem them anti-VEGF unresponsive. And then I'll go on to the next thing.
I think that's great. So really robust discussions. I want to end on time, Caroline. Really great talk by you and excellent questions from the audience. I was pretty impressed that they were paying attention. Of course, more attention to your talk than mine, but I'll take it. But it's fantastic to have these great questions. So we want to thank you for that. I know there was a question about COVID and fungal infections. It's outside the scope, plus, you know, it's not been a problem here, so we can't address that question. But thank you again for the questions. Again, the evaluation instructions will be sent in a separate email within 2 hours after the completion of the webinar. Please complete your evaluation in 14 days after attending this activity, and the certificates will be emailed to you immediately after completing the evaluation. If you have any issues with that, please contact the MedNet team so that they can help you. Again, I want to thank all the audience for attending this activity with me and my good friend, Caroline Bomal. I hope you learned a lot about new paradigm for treatment and management of retinal vein occlusions. And Caroline, thank you again for taking the time out to do this activity with me. And I want to thank everybody. Have a good day.